And there we go. Good morning, everybody, or good afternoon, or good evening, wherever you are. I know we've got people from all over the world. My name is Kathy Rossi. I am the current president for the Academy of Forensic Nursing, and we're very excited to have you guys here today. Our presentation today is on violence in the workplace, a discussion on organizational violence, lateral violence, and bullying among nurses in the medical community. And we're very excited to have Dr. Amanda Flynn here to join us today. So just a few disclaimers here for those of you who have not heard this before. Basically, we want to make sure that you understand that the views and opinions that are expressed here of this presentation are those of the authors and do not necessarily reflect any institution or organization and its partners and the other authors' professional associations unless otherwise stated. Also, this is an Academy of Forensic Nursing work product. We would ask that you to please not take any photographs or any screenshots or share this without the author's permission. Next. And that's exactly what I just read. Sorry about that. I skipped a slide ahead. Next. While the authors bring evidence of the topics that are discussed, evidence does emerge daily. It is your responsibility as a licensed professional to seek out, understand, and implement the best evidence for your specific practice. The author, presenter, and the Academy, we assume no responsibility for your practice. And next. And this is the title slide again. So I'm going to actually ask for the bio slide once more if we could, and I could go ahead and introduce our speaker for today. Dr. Amanda Flynn is a doctorally prepared nurse who graduates from the DNP program at Chatham University located in Pittsburgh, Pennsylvania. She is a board certified family nurse practitioner from the ANCC and graduated with a BSN and an MSN with a focus in family practice from Maryville University located in St. Louis, Missouri. She is an assistant professor of nursing at a private nursing college located in St. Louis, Missouri, with over 22 years of nursing experience in the ICU, cardiology, vascular, CVICU, PICU, and PACU areas. She is very well versed in the art of healing. She currently serves as a member and a SIG chair for the Academy of Forensic Nursing in the Cyberbullying and Cybercrime Division, and she is a published author with a focus of scholarship in cyberbullying, workplace violence, and workplace. We have workplace violence in there twice. Okay. And I'm going to go ahead and hand that over to you, Dr. Flynn. Thank you so much again for doing this for us today.
Oh, you're welcome. Welcome everyone to the webinar. We're going to go ahead and get started. The polling questions, I think
I can launch those for you.
That's fine. A few of these polling questions, we'll go ahead and launch them if you could just answer them to the best of your ability. So have you ever been a victim of bullying, organizational violence to your knowledge? Are you aware of any organization that might try to denigrate other organizations with similar goals for professional or financial gains? Have you witnessed direct or indirect bullying in the healthcare community, including but not limited to nurses, doctors, PAs, NPs, EMTs, I believe, or it says, or paramedics? Do you know any tools or coping mechanisms that can circumvent bullying, organizational, or workplace violence? Yes, it's interesting to note before we get started, the incidents here. So have you been a victim of bullying? We had 71% that actually said yes. Statistically, it's actually a little bit higher than that. Statistically, nurses, about 84% are bullied at work. Our other healthcare organization affiliates such as EMTs and paramedics, it is around 75%. In the don't know, hopefully with these polling question or this presentation, maybe you'll be more aware of what exactly bullying is and whether or not you've been a victim. We go down here, people that indicated that they are aware of an organization that tries to denigrate other organizations with similar goals and or professional financial gains. This is lateral violence organization on organization, which actually in the private sector is very common. People like to, instead of working collegially, they want to work against each other for their own gains. Trying to slide. Okay. Witnessed direct or indirect bullying, 100%. That pretty much speaks for itself. Everyone that is on here has either witnessed or direct bullying or indirect bullying to our healthcare community, which is obviously shining a light that something needs to be done. 71% indicated that they actually know some tools or coping mechanisms that can circumvent bullying. Unfortunately, 29% said they do not. Towards the end of this particular presentation, I will give you some tools. I also can share with you some very important websites and links after after we conclude, for anyone that's interested in. I'm going to go ahead and close this. Okay, let's get started. So what is violence? Well, the World Health Organization defines violence as the intentional use of force, power, threatened actual against oneself, another person, or group or community, which results in or has a high likelihood of resulting in injury, death, psychological harm, maldevelopment, or deprivation. In addition to this, workplace violence is not an act or a threat. Workplace violence is an act or a threat of physical violence, harassment, entertainment, or threatening disruptive behavior that occurs at a work site. It can range from threats or verbal abuse to physical assaults and, on occasion, unfortunately, homicide. These statistics are backed by the World Health Organization and OSHA. The World Health Organization, as recently as 2020, identified workplace violence as one of the biggest problems that occur for any employer or employee. When we dig down, we need to figure out what is actually workplace violence. Is it the same? Well, the definition of workplace violence is an act or a threat of violence involving an explicit or implicit challenge to personal safety, well-being, or health, and or threatening disruptive behavior that occurs within many healthcare facilities. Workplace violence can include the following: a threat of physical force, sometimes sexual assault, harassment, intimidation against a caregiver or employee that results in and or has a high likelihood of resulting in an injury, psychological trauma, stress, regardless of whether the employee actually sustains a physical injury or one that you can actually see. We have to remember that psychological injuries are just as powerful and sometimes worse than physical ones. Most folks can heal from a physical wound, but the psychological trauma that one occurs or is inflicted on one can be there for a lifetime. Many times an incident involving the threat of a firearm or sometimes a dangerous weapon can occur, but on most likelihoods in healthcare organizations or in hospitals or clinics, it's actually they use common objects as weapons, maybe a phone, a hairbrush, a soda, a tray. Regardless on whether or not the employee sustains an injury, it is still considered an act of violence. This culture of silence that we have currently, it is perpetuated by underreporting and the lack of significant interventions. This is prominently in all employer sectors, not just healthcare organizations. But as we talked today, this morning, about workplace violence specifically to healthcare workers, it is alarmingly so that overall, healthcare workers are more often than not victims of different types of violence. So the WHO has classified workplace violence into two categories: physical or psychological violence, and both are all too common today. In the United States, the cost of workplace violence is growing by leaps and bounds. We have over an 88% increase in the cost survey. There is the most recent cost survey, because they don't do it very often, was in 1992, and that was cost about $4 billion. What does that include? Well, loss of work. A lot of times it is not just direct cost, but it's indirect cost. People leaving work, people who no longer want to work in that particular environment any longer. And so then we have to rehire and retrain. In Canada, they also did a study, and they indicated that we had a 90% increase since COVID. Why is that? Well, when we increase our stress loads at our work, on top of being already in a employer-employee situation that is already stressed, verbal abuse and incivility becomes paramount. People are financially stressed. And then on top of it, they may be working shorthanded. They may not have the proper PPE that is required. This all kind of compounds and causes more incivility and bullying. So according to the Occupational and Safety Health Administration, OSHA, nearly 2 million people in the United States are victims of workplace violence every year. These incidents could be that staff are being abused, threatened, assaults, but it's usually circumstances that are directly related around their work. Workplace violence in healthcare sectors not only affect the healthcare providers or professionals themselves, but the whole environment. So we have a breakdown of the ability for the caregiver to give care to their patients. This can result in what they call absenteeism or presentism, that the individual who is being bullied or is experiencing some sort of psychological violence is distracted. And as we all know, medical errors are some of the things that cause the most deaths worldwide. So it's contributing to this.
Dr. Flynn, we've had a question or comment come in about something you said about the World Health Organization.
Sure.
So I thought before you kind of got completely away from that might put it in here.
Sure.
An attendee said, according to the World Health Organization, violence is defined as the intentional use of power or force. However, a lot of violence is experienced by healthcare workers, even by patients that do not have intention but still commit acts of violence, especially patients with some cognitive impairment, whether it's permanent or temporary.
Correct. And so with the physical, we have psychological and physical violence. The World Health Organization also talks about biting, pinching that occurs from our patients to providers. When we talk a little bit more and we get into the statistics later in the slides, you'll see that the high incidence of especially emergency room workers, nurses, 100% of nurses say that they've been abused in some way, shape, or form in their current work environment in the emergency room. So yes, we can have both physical and psychological violence. It's supposed to be intent, but when we get into people who are demented, what can we do to prevent that? Well, healthcare organizations can help you by giving you tools of how to dissuade that type of behavior so that you can protect yourselves. And as we talk through this particular webinar at the end, I'll talk about that there's not one thing that can prevent it. We use different tools, that there's just not one like golden, this is what we're going to do and it's going to prevent workplace violence for everyone, including non-intentional. The problem with the non-intentional is what is the organization doing to protect the employee? So, and we'll also talk about that later on this morning. Unfortunately, most of the stuff becomes unreported. So are you supposed to report it? And is the person or the perpetrator, what if they were demented, maybe they weren't? Who is responsible for that injury? So I hope that answered that person's question or comment.
Yes, it did. Thank you.
Okay. So many times the work stress, patient expectations. So what if a patient expects you to do A and you do B? This actually causes an increase on the physical violence against healthcare professionals, also the verbal abuse that occurs. Before we start going into how we should develop different policies and interventions to combat it, we have to understand the prevalence and the severity of the workplace, like the physical violence and the psychological violence that our healthcare workers experience. There's one little statistic that I'm going to put in before we talk about anything else, and 1.2% of workplace homicide victims in the United States actually happens on the campus of hospitals. That's a little too much for me. I know at 1% people think, oh, that's not a lot. That's a homicide. That's not something to talk about. I mean, we need to talk about this. 65% of healthcare professionals have been physically abused or injured. So, and this has to do with patient-staff relationships and how the workplace can protect those employees. So let's talk a little bit about the different types of violence, since our guests was asking about that. So there are 5 major types of workplace violence. This is according to the National Institute of Occupational Health and Safety. There is criminal intent, customer-client intent, worker-to-worker, domestic violence, and ideological violence. So let's break it down just a little bit. Type 1, so criminal intent. Criminal intent in the workplace is where a perpetrator has really no relationship with the targeted establishment, and their motive is usually theft. This generally is like shoplifting or robbery, or maybe trespass that becomes kind of violent. Most of the times the targets of criminal intent is like people who are exchanging cash. So maybe our cashiers in our cafeterias, or people that work in our cafes that are in our hospitals. And oftentimes those folks, they work late hours. They might be working alone. Or what if you're getting robbed? So if you work in a big city and you're walking out to your car and it's late because you maybe work the 11 to 11 shift, and you get mugged. That's a type of workplace violence, and that is criminal intent. Type number 2, customer-client intent, is during like a perpetrator is a customer or a client of the employer, and then the violence occurs in conjunction with the worker's normal duties. Occupations that are highest risk for this violence usually are us, so the healthcare providers, social services, and we are 4 times more likely to become victims of this type of violence than the average private sector employee. And these are some statistics from the Bureau of Labor and Statistics that track workplace violence. Remember that our patients are our clients, so this would be that particular type of violence. So worker-to-worker violence is the 3rd type. Worker-to-worker violence is generally perpetrated by a current or a former worker, and it's usually a motivating factor for interpersonal or work-related conflicts, maybe a job loss or traumatic event. The highest incident group for this particular type of violence is our managers and our supervisors and administration. Somebody who's disgruntled, who comes in, who shoots people because they've lost a job, or if they've been let go, or maybe they were being incivil and bullying folks, and they were reprimanded, and they want retaliation. This actually is a very common, unfortunately we see it on social media and in the news, that folks who go in and shoot up or stab somebody. So it's an unfortunate thing, but it does happen. The incidences are more for in the private sector. For this, we had on occasion had former nurses or physicians who come in and actually become homicidal. The 4th kind is a domestic violence. So domestic violence in the workplace often is perpetrated by someone who's not an employee or a former employee. So this would be a spouse or a significant other. It's kind of frequent, unfortunately, because the abuser knows exactly where his or her spouse works and when the working hours are, and kind of the ins and outs of that particular. Women usually are more targeted more frequently than men, and the risk of violence increases when one party tries to separate from another. I have an unfortunate story here in St. Louis quite a few years ago. The worst type of domestic violence I ever saw was actually a nurse who was leaving work. She knew she was estranged from her spouse. Her coworkers took her to her car. She was parked on the top of the garage. Her coworkers left. She was kind of fumbling with her keys. Her estranged husband was actually waiting in between cars and stabbed her 54 times. Unfortunately, she was deceased when another coworker found her. She bled out between her cars. This just gives you a sad side note of what happened. And it was devastating for everyone. And this is probably the most extreme. Unfortunately, it does happen, and we need to know how we can protect our fellow employees or maybe coworkers, and how, especially from this type of violence, and give them the tools that they need. The fifth type of violence is ideological violence. Ideological workplace violence usually is directed specifically at an organization, its people, its property, for ideological or religious or political reasons. The violence usually is perpetrated by extremists and value-driven groups just to justify their beliefs. Like active shooters, terrorist incidents across the globe usually fall within this particular type of violence. Something that would be more common would be something like a maybe Planned Parenthood or an abortion clinic that people are protesting against violence because their views do not match with the organization itself. Unfortunately, there's other things, such if the hospital or maybe the healthcare provider is a Catholic provider, and somebody is, very against that, they may target the building or the cars of the individuals that work there, sometimes the individuals as well. So we're going to get into a little bit of bullying. So, is bullying workplace violence? Yes, bullying is a common form of workplace violence. Bullying is defined as unwanted, aggressive behavior that involves real and or perceived power imbalance. The behavior is repeated. It has the potential to be repeated over and over again. And usually these behaviors have detrimental effects on the recipient. There's different types of bullying. Usually workplace bullying is in person. Unfortunately, with this day and age of social media, I'm not going to get into too much details, but cyberbullying also follows our healthcare providers. We have individuals who follow our healthcare providers, maybe follow them on Facebook or Instagram, and maybe they did not like the care that they liked, the care that they received. They find them and post negative comments incessantly on social media. Remember that it can be by email, it could be by text, it could be by phone. Any of those are considered a cyberbullying, a type of cyberbullying. Recently, StopBullying.gov, which is a governmental-run anti-bullying site, said that bullying is usually unwanted. It's usually it's a power imbalance. So if we know a little bit about a power imbalance, it's a perceived power imbalance, that I have a power over this individual. If I say this or I say that, or it could be something as small as rolling your eyes. It could be passive aggressive behavior. All this is workplace bullying. The issue for nurses being bullied at work is so prevalent that a few studies stated that 85% of nurses are actually bullied at work. It also unfortunately found that the most likely perpetrators of that bullying are fellow nurses and physicians. Unfortunately, that has to be education and being aware being socially aware, that like microaggressions and the brief commonplace like indignancies, like degrading somebody based on a political platform or a race or a membership to a marginalized group. This is all covert bullying, and to be a little bit more conscious and cognizant that that type of behavior needs to be stopped. You cannot just be a silent bystander. It's called stand up. You stand up for the folks that can't stand up for themselves, because one day you could be the one that can't stand up. And we need to make sure, especially in our healthcare organizations, that we shore each other up. Nurses, look after the physicians. Physicians look after the nurses, the EMTs, the PAs, the NPs, even our janitors. If somebody has unwanted, you see this repetitive behavior time after time, somebody needs to stop it. And if that person is powerless due to that power imbalance, it could be hierarchical, it could be it could be for many reasons. It could be that it's an old nurse and a new grad. It could be a new grad on an old nurse. It could be a new nurse on a physician. It could be a resident on a nurse. It could be any of these things. It's usually not about, bullying is never really about a single isolated event. It's usually a pattern of events that's persistent, and it's directed specifically towards one employee or maybe a group of employees. It also, there's some studies that show that unfortunately the reason why bullying is so rampant in nursing is that there's a perception among nurses that it is the way that it is, and that it's okay, and that their supervisors, the management and administration let it go. That basically they just need to toughen up, and that's not something that, basically nothing physical happened, so therefore we don't do anything about it. Being aware of what the mitigating factors for bullying sometimes include, like violence prevention programs, some structural empowerment of nurses usually works. But like I'm going to talk about in a little while, there's not one real tool that works. It's a combination of a lot of tools to get to a common goal. Because as we know in medicine, it's the art of medicine. It is meaning that what works for one doesn't work for all. So preventing workplace bullying is really important to reduce like clinical nurse burnout and turnover. Leadership really needs to be involved to develop these interventions to stop this type of bullying, and hopefully create some sort of professional and supportive work culture. Remember that workplace aggression doesn't usually happen in a complete social vacuum. Like people are aware of what's going on and they continue to allow it to happen. Usually it's because of some sort of psychosocial or organizational structure, climate, maybe a supervisory type style, interpersonal relationships, and it needs to I guess light needs to be brought to it. Oftentimes that psychological harm makes it hard for the individual to feel safe, have a safe well-being. It impacts their health, their sense of security, and usually leads to burnout. And the nurse physician, unfortunately, either will quit. Suicide is sometimes a route that they would take, and unfortunately, homicide is another route. So incivility is very similar to bullying, and this is just like rude and disrespectful behavior, and it usually violates the organizational norms, usually has an ambiguous intent to harm. So basically the eye rolling, the sighing, the huffing of the shoulders, just being kind of rude to one another. It's a low intensity deviant behavior. So it's actually, incivility is defined as a low intensity deviant behavior with the ambiguous intent to damage the target by breaking the norm of mutual respect in the workplace, Usually uncivil behaviors are just rude and discourteous, and they reveal a lack of respect towards one another. Unfortunately, workplace incivility has a significant correlation with the professional burnout. A recent study by author Bambi in 2018 showed that incivility caused emotional exhaustion, cynicism, poor job satisfaction, and it was touted at 67% of individuals in the healthcare organization in sector were either a participant of incivility or they were a target of it. Workplace incivility among peers, especially nurse on nurse and physician on physician, is much more common and acceptable, although it is a quiet acceptance. Like I said before, that go along, get along, it's always been this way, and toughen up. That type of behavior and those thought processes probably needs to stop. Is workplace violence underreported? Absolutely. So if you look at a couple of these statistics, in 2015, the edition of Injury Facts for the National Safety Council, they raised concerns that non-fatal injuries and illnesses are grossly underreported. 2 million workers have reported being victims of workplace violence each year. However, unfortunately, there is fears that many more cases become unreported. Many oftentimes businesses fail to report non-fatal injuries and illnesses due to lack of awareness or a lack of communication or a lack of incentive, i.e. there's a lot of paperwork that goes along with that. You weren't hurt, toughen up, move on. Unfortunately, when no physical injury has occurred, such as like non-physical aggression, bullying from patients or coworkers, it causes some serious psychological ill health, decrease in productivity, increased job turnover. In underreporting actually leaves hospitals with a full and complete picture of the amount and gamut of violent crimes and events that happened, and it actually hinders the development of preventative efforts. So when one of the guests actually talked about those individuals who, patients who are demented, a lot of times, well, probably 9 times out of 10, those incidences are not being reported. Yeah, or they're not followed up on, or there's no charges pressed. 52% of all workplace violence incidences recorded are in healthcare. So this kind of shows a glowing light that our workplace incidences that are reported, if 52% of them, of all workplace violence are being reported by the U.S. Bureau of Labor and Statistics. Think about the ones that were not reported. Think back a time where, have you ever been cursed at? Have you ever had something thrown at you? Have you ever had a patient grab your arm? Have you ever had a fellow nurse tell you off? Have you ever had a physician yell and scream at you or throw a chart at you or, throw an instrument? I mean, these are the things that we just kind of push aside, but it does leave its scar because things build up and people get to the point where they no longer want to be a part of the violence, that they can't take it. So what are the statistics? Well, earlier in the webinar, I talked about workplace violence in the emergency department. If you can see, 78% of emergency department physicians and 100% of nurses experienced violence from patient within the last year. Think about that, 100%. I think that's a little much. We had 46% of nurses reported some form of workplace violence during the 5 most recent shifts. Okay, so let's look at that. 5 shifts. Well, most folks, that means 6 shifts. You work 6 shifts in 2 weeks. So 80% of the time, you had some sort of violence. You were touched by some sort of violence. That seems staggering to me. Specifically, to go back to one of the persons who talked about demented patients, 59% of nurses' aides reported being assaulted by patients weekly. This is showing how actually bad our workplace is. A lot of times it's unsaid, the unspoken. We don't want to talk about these kind of things because then we have to do something about it. And can we do something about it, and what works? Some of the other types of statistics that we don't want to hear is that between 2000 and 2011, there were 154 shootings, and they were inside or on the grounds of American hospitals. Workplace violence study conducted that a lot of times that urban areas are harder hit with this, and that in rural and townships, smaller, they actually have a lower prevalence of workplace violence from patients. So it's usually equal. Men and women are both victims of workplace violence in the healthcare. It's about 0.2% difference, male versus female. There was a recent study that polled 26,900 nurses, and 49% had experienced one episode of violence in the last year. 20% had been physically violent, and another 50% had exposed to non-physical violence. Statistics like this, I mean, I guess it falls on deaf ears sometimes, that basically that's what you chose. That's the healthcare. You went into the healthcare field knowing that this is a possibility. However, it shouldn't be the norm. Work stress, a lot of times low social support, are all associated with the non-physical violence, like verbal violence towards nurses, and a lot of times violent threats towards physicians are actually very common as well. Give you a little bit more statistics here. 8 in 10, so 80% say violence in the emergency department harmed patient care. This is something that we should probably take note of. If these events are affecting our ability to care efficiently to our patients, and our patients' care is suffering, something needs to be done about it. Nearly half of the emergency physicians have been physically assaulted at work, so 6 in 10. And 7 in 10 said that their hospital reported the incident. Only 3% press charges. So a lot of folks that I have polled, nurses and physicians, say that what's the point of reporting it? They're not going to press charges. Even if the person was sentient and alert and oriented and aware of their surroundings, the likelihood of a hospital pressing charges on a patient is almost zero. I actually was a victim of workplace violence myself, and ended up having 4 surgeries due to a patient event. So I'm a little bit, and the hospital refused to press charges, and to make incident on injury, they did not want to pay for the injury as well. So this just shows you how under-supported nurses and staff are once they are injured, that basically they want you to hush-hush about it. Half of your hospital said that they can actually do more, that they want to, put in cameras and metal detectors, increasing visitor screening, especially in the emergency department, but I don't think that that's going to change. We need a mindset change and a functionality change, meaning that we need the process needs to different change. This is from the ANA, that 1 in 4 nurses are assaulted, and only 20 to 60% are reported. And then if you see this last statistics, 13%. So we're going to talk a little bit about lateral violence. What is lateral violence? So lateral violence is when a person exhibits harmful and hostile aggressive behavior towards a coworker or a group of coworkers. So this is a little different from patients on patients. This is actually, usually it's coworker on coworker or someone. These are like those little snide comments that you would get from a fellow coworker, maybe being sarcastic, possibly belittling gestures, inappropriate or unjust evaluations by management or supervisors. maybe withholding information so that the person does not get a promotion, and then holding grudges or displaying some sort of favoritism. Lateral violence can take many forms. Usually these verbal or physical behaviors produce a risk for health and safety of the healthcare interventions at delivery. So just think about it. Are you going to support a fellow nurse who just made snide comments to you when their patient is going in the toilet? No, you probably wouldn't. I mean, I have never done that necessarily. Patients come first. However, it does happen. It makes people less likely to want to help one another out, and then it breaks down the ability for the healthcare organization to work as a team. A lot of times lateral violence are consistent behavior patterns. They're planned to aim to control, belittle, or devalue someone or a group of individuals. And this is actually, it's a little bit different than bullying, and it's a little bit different than incivility. This actually is like a comment or a gesture, or actually withholding information or being inappropriate. This also can be sexually inappropriate. Maybe somebody stalks, you work with somebody and they send you texts or comments. It's lateral violence, but it's in a form of cyberbullying. Workplace violence and lateral violence can lead to increased stress levels, absenteeism, chronic fatigue, sleep disorders, reduced level efficiency and productivity in healthcare. It can negatively impact the quality of working life, negative job satisfaction levels, suicide, unfortunately, homicide. So lateral violence negatively impacts both the work environment and the nurse's ability to deliver optimal patient care. Even if workplace incivility persists, or it represents just the precursor, the workplace violence phenomena shows up when harassment and lateral violence start to emerge. So basically, this is the beginning. Harassment usually is described as abusive behaviors with a systematic intent to damage the target. It's usually based on like gender, race, sex, maybe some sort of disability differences, but lateral violence usually is consistent with behavioral patterns, and that is the aim of to control somebody. Verbal behavior is usually the most common type of lateral violence, and it sometimes can involve both professional or personal intent. So basically, maybe a physician that made a comment. This would be an example of lateral violence. Usually it's can be called covert hostility. Maybe it could be criticism. Sometimes they sabotage another nurse, or a physician sabotages another physician. It's very damaging. They're maybe looking for a scapegoat. There is a lot of personal consequences of incivility. A lot of psychosocial and professional problems that arise with this type of behavior. And unfortunately, the side effects of this type of behavior can range from insomnia to irritability, maybe some psychosomatic symptoms, until that it progresses to post-traumatic stress. Unfortunately, it can sometimes leads to contemplation of suicide. In the news recently, we had a very, very, I believe is in the UK, a physician who killed herself because she was being bullied at work. Something, the phenomena happens a lot in the professional realm. It directly correlates for poor patient care, and it happens often. As the incidences increase, the the nurse will a lot of times will have such poor job satisfaction, they may want to leave the profession completely. We already have a shortage of physicians and nurses. That's the last thing that we need. And unfortunately, this type of lateral violence usually is impacted the most the first 5 years of a nurse or a physician's job, basically the length of service of the first 5 years. And when it is at its worst, they say, I'm due to bullying and victimization, I'm out. I can't do this anymore. So how does workplace incivility and the pandemic impact current workplace environment and foster a world of eat your young mentality? And this is i.e. bullying. Well, let's see. Where do we start? Increased workloads, no compensation, healthcare providers forced to use the same PPE for long periods of time. There is actually documented incidences that PPE is being locked up by management. Poor communication from the administrator on how to be safe in this particular pandemic. Lower staffing levels can cause a lot of healthcare providers to have limited time or energy to teach or onboard their nurses. So basically they're on their own. That leads back to that eat your young. Like, I have no time for you. I can only do me right now. This stress can lead to irritability and bullying and uncivil behavior, to the added stress of caring for individuals who have COVID. Maybe they may not have any family visiting during their death or during that severe illness. And so not only is the healthcare provider providing care for the patient, then they're also being their surrogate family. They call that caregiver fatigue. Stay-at-home orders cause frontline workers to become teachers of their small children at home. In the addition of those extra duties on top of their job, they are unduly stressed, and they do take it out on that first 5 years, those physicians and nurses and EMTs and PAs and NPs that are there the first 5 years, the folks that have been there longer who have this added stress. It just leads to it's a cyclical event. It just gets worse and worse and worse. They bully, they get poor job satisfaction, then all of a sudden they're bullying even more because they're more and more unhappy, and it's just a cycle. The stress of spreading the illness to their families also impacts their ability to do their current jobs. They're very afraid of bringing it home. They're also worried about retaliation of companies for employees discussing like the current PPE situations. And many times this positive association between this type of workplace stress and medical errors. It causes lower quality of care for the patients, and usually is attributed to their inability to function at this specific level. A, because they're being bullied, and B, they have all this other stuff going on. This is not an isolated incident. This is impacting the worldwide. How does workplace incivility and the current financial crisis impact the workplace environment? Well, we have elevated accidents, we have absenteeism, presentism, we have low morale. There's ethical concerns over specifically like how ethical is this healthcare organization being to their employees? Are they making them work and not getting compensated for it? Are they having to give up breaks? Are they working in unsafe environments without PPE? The high turnover. So a lot of times individuals who are financially strapped exhibit signs and symptoms of anger and guilt, anxiety, and depression that leads to poor work attention and all of these things, accidents and absenteeism and presentism. So even though if you come to work and your mind is not there, that can lead to medical errors. We need to be aware that our nurses and physicians and healthcare providers across the globe need to use their EAP. So what is that? Well, it's here in the United States, most employers have an EAP, which is an employee assistance program. They can help set up counselors with the employee to help them through stressful environments and stressful times. And then if they meet certain criteria, get to a psychiatrist or a psychologist that can help them through this. So many times healthcare workers just shouldn't take short breaks during their day to deal with the situation, maybe meditate or try to relax as much as they can. And unfortunately, when we have ethical concerns that healthcare organizations may or may not be giving them the time that they need, they may not be able to decompress. Why is it important to identify and combat workplace violence and bullying and civility? Well, let's see, 400 physicians committed suicide in 2016. Suicide completion rates are higher for physicians and nurses than the general population. The suicide rate for male physicians is 1.4 times higher than non-physician males, and it's 2.27 times higher than female physicians. I'd like to highlight this last statistics. Female nurses are 23% more likely to commit suicide than non-female nurses. Well, I think that speaks for itself. If you're a female nurse, you're 23% more likely to commit suicide than the general population. In our high stress environments, bullying it's much more likely to occur, especially in high stress settings, high stakes outcomes. People have heavy workloads. They have a lot of times have low job autonomy. All or maybe partial of the nursing profession and healthcare in general meet into this category. And if that wasn't enough, the new circumstances for COVID has made it even worse. As I remember, I said earlier in the webinar, workplace aggression doesn't happen in a social vacuum. We know that it happens in relations to how our organizations deal with what the organization climate is, what the supervisory style is, and all the interpersonal relationships that go along with it. And many times, unfortunately, bullying and workplace violence is prevalent in situations where, like maybe the supervisor or the administrator, they avoid intervening to stop the stressful situations. Maybe they can get another nurse, or maybe they can get a sitter, get helping hands, and they choose not to. How do high stress environments cultivate bullying and lateral violence? Unfortunately, like I said before, is that these climates are high stakes, high pressure, and it's not spoken. So it's the unspoken, it's the unreported, it's the stand up and you need to dust yourself off and deal with it. Unfortunately, in our homes, when we're dealing with COVID, for example, we are dealing with healthcare issues, we're dealing with financial issues, and then you go to work and Susie Snowflake, the nurse next to you, is making snide comments and then refuses to help you when your patient is crashing. This cultivates a cycle of bullying. Usually the person that's being bullied will eventually bully. It statistically is 90% of folks that are perpetrators. They were victims once. You can't beat them, join them is unfortunately the culture climate that goes along with incivility, bullying, and violence, specifically in the workplace.
Dr. Flynn, we've got a question that related to something you said. Someone's asked, what is presentism?
Presentism is when you are actually physically at work, you're there, you show up, you're not absent. Unfortunately, your mind is not there. So you're unable to deal with specific situations because you're not present. Presentism is a problem at many different occupationals, different work environments. It could even be a student that's at school. You're physically there, but mentally you're not. That's called presentism. Hopefully that answers. So we're going to move on to tools. How do we fix this? How do we combat workplace violence? Well, number one, admit there's a problem, right? We need to confront violence with a comprehensive approach. We need to identify the barriers to programs that decrease workplace violence. We need to have a standardized approach to workplace violence reporting. That is not actually addressing it, but the actual reporting, because it's become so underreported that we really don't know. So the studies out there, unfortunately, when I was doing the research for this particular webinar, they talk about like a safe climate, slave culture. Unfortunately, when we talk about that, it's only about physical. So they're only tracking physical. They're not tracking psychological. And as we all know, that psychological damage can lead to PTSD and can lead to contemplating suicide. So I think that a more global approach of trying to track both and having a standardized approach to workplace violence, it is important. We need to do a risk and hazard appraisal for interventions, violence risk surveillance for physical, reduction and evaluation process for psychological. So basically we need to, be preventative, look at the cause behind the violence, not just the effects, be targeted. You can't attack every kind of violence in the same way, which I've already said before. Be multiple in the sense that combining different types of research and different types of tools should be for the responses that are needed. So basically, if we use different tools, maybe we do an risk evaluation, hazard appraisal, and then also we do surveillance, but then we also have an educational piece that goes along maybe every year or every 6 months to evaluate whether or not the process is working. It needs to be immediate. So an immediate intervention should be ready ahead of time to be proactive and not reactive. Kind of like what we do when we're ready for like active shooter drills or terrorist attacks or anything like that. We should have a process. Like I was talking about, the safe culture, safe climate, that is in effect for many organizations, especially healthcare organizations. Unfortunately, the process stops there. So we have, you have a yearly thing where you watch an active shooter, but you don't talk about bullying. You don't talk about incivility. You don't talk about cyberbullying. You don't talk about any of that. You may or may not have like a social media, quote unquote, policy, but does anybody ever read it? And does anybody ever go any depth? And like, you should not do this, you should do that. So instead of searching for just a single solution, the full range of causes that generate the violence should be analyzed, and a variety of interventions and strategies should be adopted. Unfortunately, because workplace violence is, the response is kind of limited and it's episodic, we don't know, and it's really ill-defined of how each organization should deal with it. So bringing in awareness is key. Maybe elective, like educational programs could have a positive impact. Make sure that nurses are trained to use assertive communication and also conflict management to face bullying and from patients and from coworkers. Addressing leadership styles to make sure that we have authentic relationships between our management and ourselves. Zero tolerance strategies towards any kind of abuse is really, really important. Maybe legislative changes, code of conduct for different healthcare organizations that define what is acceptable and not acceptable behaviors, what's disruptive. All of that should be addressed. In including individuals on self-awareness, self-management, social skills, maybe empathy, and management of relationships, such as interpersonal abilities, should be addressed. These are all life skills that we can actually help our fellow nurses and physicians overcome some of this negative. So enhancing the safety climate via like maybe a educational program will help increase the number, decrease the number of aggressive incidents towards staff or patients. And like I said, there was really no previous studies that examined like safe climate or detriments to, it's all about physical violence. It wasn't verbal. Work stress relief would be also great. If we could probably deem if the efficacy of a violence prevention climate, if it was as effective as it is for physical violence, then we would be onto something. Interpersonal conflict, working with the self-management, self-care, because personal conflict is usually the #1 precursor to verbal violence on each other. And making sure that we understand that it is common. So coworker violence and incivility are really common in hospital environments. And usually it has to do with work-related factors. Unfortunately, sometimes it's non-work related factors because a lot of folks meet their significant others at work. The one thing that, before we go, there's a statement from the ANA on workplace violence. And I wanted to read it verbatim. I do not have it memorized. And the reason why I think it's important is because it kind of sums up my thoughts on workplace violence. So this statement is not my own. This is actually from the ANA, which is the American Nurses Association. It stated that it's best in the nursing profession that they will no longer tolerate violence of any kind from any source. All registered nurses and employees of all settings, including practice, academia, and research, must collaborate to create a culture of respect, free of incivility, bullying, and workplace violence. They also put a position statement that's a little bit more than just that. It says that employers have a responsibility to create and sustain a culture of respect, free of incivility, bullying, and workplace violence. Registered nurses and employers across the healthcare continuum, including academia, have an ethical, moral, and legal responsibility to create a healthy and safe work environment for registered nurses and all members of the healthcare team, healthcare consumers, families, and communities. I think that pretty much sums it up. I do have some resources on cyberbullying, cyberstalking, some workplace violence tools and resources for healthcare providers that I'm sure that the AFN can send out. It's a link of about 20 different organizations. I'm not specifically affiliated with any of them. However, it is some great resources.
Okay, what we'll do is we'll see if we can include that link in when we send out the certificates of attendance for this webinar.
Sounds great. Here are just a few of the references. And so questions and discussion.
So far, this is Kathy Bell. So far, we just have one question, and it may relate to what you just talked about. Is that this is really, really good. So she really appreciated the presentation. And will there be handouts available? So I think
Yes.
you answered that.
Yes.
I'm not sure if she meant specifically the slide presentation, which I know will be posted in Colleague Cafe, I believe, too.
Yeah, and the actually, it's interesting because I did a piece for the Emergency Room Nurses Association with tips and tools for workplace violence and resources for healthcare providers, including cyberbullying. I'm hoping to do, my specialty is cyberbullying. I tried not to get off on tangent for the cyberbullying section, but there's a lot to share with that. So in the future, we might trying to do a specific webinar just on cyberbullying, cyberstalking, cybercrime.
Absolutely. So are there any other questions out there that you'd like to included in the Q&A, and we'll get them to Dr. Flynn.
Okay, well, I think that since we're just a few minutes over, we'll go ahead and wrap up. If you guys do have any questions or you have anything you want to reach out to us about, feel free, you always can reach out to us at afn@afnmail.org. We will go ahead and get you out the certificates as soon as possible. And just a reminder that we have a photography boot camp coming up for forensic nurses. It's going to be online virtually in November, starting November 5th. And we'll have some registration information up on the website very soon for you. Thanks again, everybody, for joining us literally from all over the world today. And thank you again so much, Dr. Flynn, for taking the time today to come join us and share that information with us. I really, really appreciate it. It was very informative.
Great. Thank you so much for your time.